Okay, perfect. Thank you very much. Good morning, good afternoon, and good evening to everyone now participating in this course called the Climate Ready Classrooms, Public Health Faculty Development course on climate change. It's a great pleasure to have you all here this morning, afternoon, or evening, depending on where you are participating from. You're now joining to the 10th session with the title Climate and Mitigation, Sustainability within the Health System and Health Co-Benefits in 2025. My name is Eric Toomey. I am the ASFA Fellow in Climate Change and Planetary Health at the Association of Schools of Public Health in the European region. And it's my great pleasure to be moderating today this session. I'll just quickly go through all the formalities that most of you will be already very familiar with. So this course is available in different languages. For the English caption, click the CC button in your Zoom window. And we also have the course captioning in Spanish. So please click on the link in the chat. So este curso también tiene subtítulos en español. Entonces hagan clic en el enlace del chat para accederlo, por favor. So, as most of you will know, we are now today at the penultimate session of this course, session number 10. The course objectives are mainly consisting out of two. It's first to equip public health faculty with a deep understanding of the science of climate change, its drivers, and its direct and indirect impacts on health, enabling them to confidently integrate climate health concepts into existing public health curricula. And second, to prepare educators to guide students beyond theoretical knowledge toward applied skills in risk assessment, health system resilience, community engagement, and evidence-based interventions. So we have 5 session learning objectives. This is first to analyze the role of health systems and health professionals in promoting both health outcomes and environmental sustainability, and how these dual goals can contribute to a more resilient healthcare delivery in the context of climate change. Then address the role of health systems in climate mitigation through optimization of healthcare services and delivery. This spans the different components of health infrastructure, resource utilization, and strengthening the health workforce, besides facilitating intersectoral coordination for development, climate resilience, and environmentally friendly healthcare facilities. And third, explain the concept of sustainability in healthcare and identify strategies for integrating environmental sustainability into health service delivery, including energy efficient technologies and reducing healthcare related carbon footprints. Fourth, identify and describe the health co-benefits associated with climate change mitigation strategies, including improved air quality and reduced incidence of respiratory cardiovascular diseases. And fifth, explain and understand the importance of inter-ministerial collaboration for integrated health considerations into climate mitigation plans, including strategies for promoting co-benefits and monitoring health outcomes. So logistics, you will probably already well know. This is a 90-minute session, and it includes expert lectures and case study presentations. The sessions will culminate with a question and answer section, so as well today, and you can enter your questions for the presenters in the Q&A session of this Zoom call. The sessions, video recording, slide decks, and resources will be made available on the course website that you will already know, and it is very important that you must enroll in this course Canvas page via the Columbia Plus in order to have access to these materials. And to enroll, please use the link in the chat. The attendance can be tracked synchronously and asynchronously. For the synchronous attendance, this will be happening automatically when you join the live Zoom sessions using your personal Zoom link, and the attendance will not be counted if you use a colleague's link. Watching on YouTube does not count towards attendance. And for the asynchronous attendance, if you cannot attend live, you may watch the session recordings on Columbia Plus Canvas platform, where your viewing will be logged and counted toward the attendance record. And again, use the same email address as the registration, please. And to obtain a certificate of participation, the participants who attend or view 8 out of 11 sessions and pass the final exam with a score of 70% or more at the end of the course will be awarded a certificate of participation in climate and health from the GCCHE. And the final examination will consist of approximately 25 questions in multiple choice or true-false format. Participants must complete the exam in a single setting using the same email address used for course registration. And the availability, the exam link will be sent via email and WhatsApp on November 14th, 2025, one day after the final class. And the asynchronous viewing of course sessions must be completed by Sunday, November 30th, 2025 in order to count as an attendance. And the exam will remain open until Sunday, November 30th, 2025 at 11:59 p.m. Eastern Standard Time. The exam will not be reissued after this date. And you're also more than happy to and welcomed to this WhatsApp group. If you want to join, please scan this QR code. And with this, we are already at the stage of presenting our today's panelists. I'm having the great pleasure to present to you three distinguished panelists today. We will start with Fiona Miller having a lecture of approximately 35 minutes, followed by two case studies presented to us today by Linda Barangu and Arash Motamed. And with this, I would start to present to you Fiona Miller. She's a PhD and she holds a PhD as a professor of health policy in the Institute of Health Policy Management and Evaluation in the Dalla Lana School of Public Health at the University of Toronto. She is the founding director of the UOFT Collaborative Center for Climate, Health and Sustainable Care and runs a pan-Canadian initiative for climate action and awareness in healthcare, funded by Environment and Climate Change Canada, Cascades. In these roles, Fiona leads and supports efforts to improve the resilience and sustainability of health systems through research, education, practice change, and policy development. And with this, I would like to hand over the word to you, Fiona. The stage is yours. I'm going to unshare now, and then you can share your slides.
Okay, thank you. Thank you for that welcome. I'm joining you from Toronto, from the University of Toronto. These are lands that for thousands of years have been the traditional homes of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and are today the homes of many, many different Indigenous peoples from across what many Indigenous people consider to be Turtle Island. So I'm really delighted to be with you here today and to provide this opening discussion. I'll start by just saying that while I have no commercial conflicts of interest, I have many, many interests in this space, both as a researcher and as somebody who, as already has been introduced, leads work both at the university that's more research and education oriented, as well as the more practice change work in healthcare through pan-Canadian work that I also do with Linda and many others from across the country. So what I want to do is to start with a bit of an overview of healthcare's pollution problem, because there is a problem of pollution from the healthcare industry. And then we'll dig into other aspects of how we conceptualize solutions to those problems, some examples, and I will try and connect the dots to the range of different disciplines that schools of public health support. I'm in a school of public health, a comprehensive school of public health, so there's quite a few disciplines that are quite relevant in their education, in the research that they foster to addressing these challenges. Let me start with this oldie but goodie. This is a classic piece from Lenzen and colleagues that tries to characterize across standard environmental categories the extent to which healthcare has this pollution problem. So what you can see in this image to the right The circles are, the outer circle is 6%, the inner circle is 2%. This is suggesting that healthcare around environmental impact categories like contribution to particulate matter, to nitrous oxide, to greenhouse gases, to nitrogen or scarce water. Healthcare is responsible for somewhere between 1 and 5% of total global impact. So this is, for a service industry, which healthcare is, a remarkably resource
Yeah.
intensive and polluting industry. And while these data, I think, are extremely helpful for grounding us in that fact, it's helpful, and I will dig into 4 areas where we see these impacts: greenhouse gases, plastics waste, pharmaceutical pollution, and let's also turn to data, health data, and the information and communication technologies that enable that. So greenhouse gas emissions, healthcare, according to the most recent data from the Lancet Gaptown on climate and health, healthcare is responsible for about 4.2% of global greenhouse gas emissions. And the image to the right is helping you to conceptualize where those emissions are coming from, drawing on the greenhouse gas protocol. So let me walk you through that briefly. The sort of orangey pink bubble that's relatively small is what's called scope 1 emissions. These are the emissions that healthcare is directly controlling. So the burning of fossil fuels to heat buildings, to drive vehicles, or in healthcare, important directly controlled emissions like anesthetics. These are relatively meaningful, but they're not that big a bubble. Those are the ones we directly control. Scope 2 are the indirect emissions that we cause, that we induce, and specifically related to electricity. The important thing about this image is that big blue bubble, darker blue bubble. It's called scope 3. These are all the emissions that healthcare is responsible for, but neither directly nor closely controls. They are deep within our supply chains. They are in the products we purchase, the services we engage in, as well as waste to some extent. So, for example, healthcare is responsible for some portion of the food production, the food manufacturing, the food transportation that happens in the world. We induce that behavior and we are accountable for it, even though we don't control it. There's also business services and business travel, staff commuting, and important categories like medical devices or medicines. Medicines themselves are understood to be approximately 25% of healthcare's greenhouse gas emissions. So when we say healthcare is responsible for these emissions, we mean in this broad sense of accountability. We induce and directly control a small amount, but induce a significant quantity of greenhouse gas emissions to be emitted around the world. Another category that really needs named as a particular area of challenge for healthcare is plastics. Healthcare is highly dependent and indeed increasingly dependent on plastics. That dependence is in our elaborate use, and it varies across jurisdictions, but in many contexts, very, very elaborate use of packaging, as well as the growing use of single-use devices and supplies. And in fact, when I say growing, it is true that the general global trajectory still appears to be the growth of single-use devices, for example. Some manufacturers that are pulling older reusable devices off the market. So there's many, many things, and the images to the right point in the direction of that. So plastic is one of these incredibly functional materials. You can make it soft, you can make it a textile, you can make it hard. That functionality and the upfront low cost or price, as well as the potential and reality, and to some extent, for sterility, is an important driver. Now, there is some excess faith in sterility that we'll come to, but there clearly is a way in which healthcare has become highly dependent on plastics. So that dependence has consequences. Healthcare is part of the global plastics waste problem, which is rapidly accumulating. It's something less than 10% of all the plastics ever produced since the 1950s have actually been recycled. The plastics use and development and waste problem is projected to grow. I think it's by 70% by 2040. Healthcare's producing anywhere from 20 to 40% of the waste that healthcare produces is from plastics. It's going to vary. So we're very much part of a global problem of a product that we really do not know how to deal with adequately. It's also the case that plastics are full of chemicals, the vast majority of which are petrochemicals, and more than 4,000 of them are known to be hazardous. And in the other cases, we generally don't know. So we know that these are chemicals that have impacts on natural hormone cycles or increased risk of chronic diseases. And there's growing evidence that micro and nanoplastics, what plastics break down into in the environment and then get into our bodies, that those are creating very real health risks for people. The other thing that we have to be recognizing about plastics and our dependence on plastics is that we're sustaining the petrochemical industry. Plastics and the development of virgin plastics is a growth area for the petrochemical industry. So this is part of the overall challenge. So the next category that I think is worth really focusing on and that healthcare has a particular responsibility for is pharmaceuticals and the pollution from there. So pharmaceuticals, specifically the active pharmaceutical ingredient that responsible for the biological impact, pharmaceuticals are designed to be stable and bioavailable. That's the intent from a health perspective, but of course that means that they are stable and bioavailable, so they persist and accumulate in the broader environment. And there is known ecotoxicity from some and a lot of absent knowledge. There's a lot of limitations in our evidence base about the ecotoxicity of the pharmaceuticals that are persisting in the environment. But there's harms to many, many species in the environment, as well as risks to human health because these products are reconsumed through our water supply and through contaminated food supply. The other category of challenge here is the way in which healthcare's consumption of antibiotics is contributing to antibiotic resistance. So when we think about where pollution, pharmaceutical pollution is coming from, there's three broad categories that people are pointing to. One is when they're manufactured, and that's true. There can be releases and sort of concentrated pollution of pharmaceuticals. There's also a lot of focus on improper disposal, flushing those drugs down the toilet or putting them in the regular garbage. But the real problem of pharmaceutical pollution is actually appropriate use. 30 to 90% of the API that we consume is actually excreted as a still active product. It's not fully metabolized. And so that is what goes into our water supplies, and our sewerage systems are not designed for the most part to manage this, to extract this. There is movement in Europe to change the regulation and to force the improvement of sewerage systems to remove these wastes. But this is a compounding problem that healthcare is significantly contributing to. And the fourth and final category that I really want to call attention to, I'm putting under the label of ICT, or information and communication technologies. And I'm talking here about both the infrastructure and the data. So one of the things that I think is quite common in all of our actions to try and make our world more sustainable is that we tend to think if we don't see it, that it's not a problem. But virtual actions have material impacts. They have impacts through the fact that the data that we generate needs to be stored, and the moves to big data and big data analytics, and I'll come back to that, have very significant energy and water demands. The infrastructure itself requires resource extraction and manufacturing with both environmental and social harms. And e-waste is one of the fastest growing waste streams in the world. So healthcare, which is estimated to be about 30% of the global data, which is a pretty big chunk, has a significant role in these particular pollution challenges. So if that's the scope of the healthcare's pollution problem, how do we think about and approach making change, making healthcare more sustainable? And I want to introduce a planetary healthcare framework from Andrea McNeil, Jody Sherman, Forbes McGain. It's a really nice framework that I would encourage people to use. It's a great way of conceptualizing what's at issue here. And so it identifies for us, and I consider this to be the fourth step. It's on the bottom of the image that I'll show you. The first step is in some ways perhaps the most obvious. Now that I've told you about all those pollution risks and harms, we're going to focus on the things we're doing and saying, how do we reduce pollution in those areas? So how, for example, do we make our buildings less energy intensive? How do we have less polluting transportation? How do we, what role can virtual care play in reducing our dependence on physical space and travel? The idea of the circular economy. How do we keep materials in use at their highest possible value for as long as possible, rather than taking a product, using a product, and disposing of a product? So those are the areas where we can think about reducing pollution from the things we're already doing. But the important thing about this framework is it takes us much farther. It takes us into this category, which to my mind is probably the most important category. It's a place where we can achieve much of the value and benefit from sustainability. So there's three big categories here. One is stewardship. How are we making sure that if we are providing pharmaceuticals, then we're not wasting more pharmaceuticals than are needed. We're, managing expiry dates and use and opening and all those kinds of things to actually match that supply to demand. A bigger category is going to be ensuring appropriateness, and I'll come back to that one. There is quite a lot of low value care that's a significant problem in high income countries, but it's not absent from low and middle income countries. And then we get into this whole question that's a big system question about matching supply and demand, which is to what extent are our health systems appropriately balanced, with a balance of primary and community care services to match those demands, not just the acute care services. So from a sustainability perspective, do we have enough of the high touch, low tech care to supply those needs so that people aren't showing up at the door for the low touch, high tech, and therefore high polluting? So the third element of this framework is when we move right upstream into the territory in many ways of classic public health, social determinants of health, and some things, not many, I would argue, that healthcare can do in this space, but some things that healthcare can do in this space. So this is the framework. This is, I think, the way we need to think about addressing these challenges. I'm going to be a bit cheeky now. As I was thinking about putting this presentation together and thinking about connecting it to public health education, I said, well, it's helpful to think about what are the practice communities that have been involved in developing this approach to sustainability, and how do they connect to different academic communities in public health and beyond. And so I'd say that what we've seen in the building of the movement around sustainable healthcare is the progressive engagement of three different practice communities, and really starting and continuing with critical work in greening healthcare, energy and environmental services. The work done, for example, to get rid of mercury thermometers in the 1990s was really critical, looking at chemicals of concern. The health protection people have been involved to some extent, particularly perhaps on occupational and environmental health, but thinking about some of the issues that matter in healthcare. But to me, the game changer, the thing that's really moved the needle, has engaged a lot more people, is what I'm characterizing as planetary health and sustainable care. And we've seen people like Jody Sherman. I think her earliest publication on this is 2010, starting to work with engineers, bringing clinical expertise to bear about what kind of practices are appropriate and needed, with engineering expertise to look at the life cycle environmental impact of those practices, so we can have sound evidence about what kinds of practices are environmentally preferable and either clinically equivalent or clinically better. So that kind of movement has really, really grown. And so the whole sustainable healthcare community, I think, and the efforts that are happening within organizations to push this forward really work across these three communities extremely effectively. And as I'll suggest, with different kind of disciplinary implications. So the remainder, or much of the remainder of my brief talk, is going to think about these three areas where we make impact: low pollution options, I'll start with, and think about the practice communities and academic communities that implies, move up to matching supply and demand, look at some examples, and then end with the primary prevention question. So here's my next section of my talk. Let's work through this with some examples. So a really good low pollution option is that people are exploring are issues of reusables. The work here is from Cascades, the Pan-Canadian initiative that I lead, that's funded by Environment and Climate Change Canada, a really nice playbook with some resources and tools that folks might be interested in, that really works through many areas that are clinical and non-clinical, where we can extend use, where we can repair, where we can reuse or keep even remanufacture single-use items. And there is good evidence from the kind of life cycle environmental assessment that shows that reusables, even when we take into account the energy and the water required to wash them, generally there's still a net environmental benefit, and it could be a significant environmental benefit. There are some context-specific issues. If you're burning coal for your cleaning, that may not be the case. But generally, reusables are going to be an environmentally preferable option that also have some benefits from a resilience perspective, as many of us experienced during COVID. So from the perspective of the different disciplines within environmental health, population health, and beyond, I'd say there's and maybe I should say, I am in a school of public health that has a very, very broad spectrum of disciplines and capacities, whether it's clinical public health or occupational and environmental health and biggie epidemiology and clinical epidemiology and health policy, et cetera. So I'm pointing to that broad spectrum of public health competencies. So there's a lot for the occupational and environmental health world to do here, to teach and to advance research on. One of the major challenges that faces reusables is the persistent concern about sterility. So I think this is an area to teach in. I think there's good examples for students to grapple with about what is safe enough, what are the real risks of contamination, do we have good standards for what kinds of products we need to be more concerned about or less concerned about in terms of infection risk. There's always work to be done from that clinical public health perspective, that bringing public health together with preventive medicine in engaging clinical practice change for those issues that touch clinical practice. And then I am a health policy prof, so I always think there's a lot of work for the health policy courses and systems management courses and health economics and those types of courses to do to address the questions of how these systems change. How do we structure our purchasing? How do we organize the regulations, et cetera, et cetera. So I want to touch on another low pollution option that's often talked about as a low pollution option, but isn't necessarily. So let's get into the question of data. And I think an important distinction is between the phrase digitization and digitalization. So what we mean by digitization is taking something that's material and turning it into a digital form. So we take a paper form that we complete and we turn it into a digital form that we complete. You're just replacing a material with a virtual. And in many contexts, you're going to be able to achieve net environmental savings there. Digitalization is different. Digitalization is actually creating whole new activities. Remote monitoring, for example. We didn't do that before. We didn't really have paper-based versions of that. Remote monitoring is something that is a new practice. So there is a lot of research and a lot of evidence, and this is a nice scoping review, that image on the right, about the many, many ways in which virtual delivery of services can, as well as sophisticated information systems, can reduce the pollution. And specifically here, they're looking at the carbon footprint of existing healthcare arrangements, whether that's improving maintenance, optimizing supply chains, reducing energy consumption. So that's a great review that points to all of those things. The challenge, and this is a recent report from Stanford on their AI index report, relatively recently out. This is their chapter on science and medicine, and the explosion of big data and sophisticated data analytics, including AI, what goes under the umbrella of AI in the clinical space, the clinical knowledge of leading LLMs, the AI's capacity to outperform doctors, the huge spike in, and this is US, but I think it's indicative of FDA approved AI enabled medical devices, et cetera, et cetera. So we are in the space of potentially massive growth in new capacities, new activities that are going to compound some of the challenges that I identified with respect to the ICT, the data dependence, the infrastructure, the e-waste from the growth of big data and data analytics in health, including health AI. There is clearly some potential for using sophisticated data and data analytics to reduce our environmental impacts. And when research is done with that intent very, very clearly in mind, there's even greater potential to yield that. That, however, is not common. most folks doing work in this space are not calculating the carbon costs of their data models. So we really do have a challenge here for healthcare that I would say there's a lot of room for our public health disciplines to be teaching about. There's lots of examples of interesting challenges for case studies for students to grapple with. These are areas where we want our students to both go into practice thinking carefully about how to navigate health data, its potential and its risks, as well as advancing research in this space. This is a nice tool. So this is from SHADE, the SHADE Research Group, which is based in the UK. It's a nice planning and monitoring tool for a responsible and sustainable digital health system. They're trying to help people understand the limitations of efficiency. So just making something more efficient doesn't reduce the overall environmental impact. In fact, there's often a rebound effect. If it's cheaper to heat our home, we will often allow our home to be warmer. And the net impact of that can actually be worse environmental impacts. There is a need to think about sufficiency in these areas and beyond. And this is a good segue, really, because we're not anymore really talking about the low pollution option. We're talking about this broader challenge within healthcare of matching supply and demand. This is the challenge of sufficiency. How do we do enough? How do we do the right stuff? And people who aren't deeply involved in health policy and health system organization are often unaware that there are real challenges of low value care. And I think this image is a really nice one. This is from what's now the Canadian Drug Agency in Canada and Choosing Wisely Canada. About what low value care is. Low value care is care that wastes resources, that provides little to no clinical benefit, because it really isn't needed by that patient. And it actually is potentially harmful to patients, both directly, because the unnecessary care may harm, and indirectly, because the unnecessary care may get in the way of the appropriate care that the patient needs. So this is an existing challenge. I'm trying to suggest that the healthcare's data addiction can make this challenge worse. So there's lots of work here, again, for our public health students to be learning about these challenges, understanding the issues and the tensions, trying to get in touch with the work we can do both clinically and from a health policy and systems perspective. And I wanted to offer another tool here because one of the ways to really help particularly clinical teams make changes in their settings is quality improvement. There's some great work in the UK. So that's a SUSQI framework we have developed in Canada through our quality improvement agencies, a sustainability embedded QI toolkit that works with similar principles and provides some really practical tools. This is a way of helping both students and clinicians in practice look at the practices they're engaged with at a fairly small level and figure out ways to make them more sustainable. And some of this is how we're going to grapple with the oversupply of inappropriate care challenge, the quality challenge in healthcare. So the final level here is this bigger issue of primary prevention or getting right upstream in terms of reducing the demand for healthcare. So here is classic public health. And I think it's helpful for classic public health to be reminded that the fundamental work that they do through intersectoral action, working to get basic things like vitamin D in milk or reduce salt or trans fats in foods, or to address the deeper social questions of food deserts or food insecurity, housing, and so on and so forth. These are fundamental commitments of the public health community, fundamental aspects of public health education, and they are deeply important to a sustainable healthcare system. I will say that I am considerably skeptical about secondary prevention as being generating a net environmental benefit. The health benefits are often not that big. They can be very meaningful to the people involved, but they're not huge marginal benefits. And so the environmental net impact there, although I think it's an empirical question, in my view, is likely not to be good. But here, of course, there is work to do within our educational settings to bring these ideas that are classic ideas in public health to bear and thinking about what this means for health systems. So I'm going to close by talking briefly about something I was asked to speak to, health benefits and co-benefits. I'm not getting into, I guess, some of the detailed evidence on air pollution, for example, or healthy diets. I'm going to talk more conceptually, perhaps, to what do we mean by health benefits and co-benefits of sustainability in healthcare. So first of all, I think it's important from what I've said to distinguish between the actual direct and intended health benefits of sustainability efforts. Sometimes we are trying to make changes in the way healthcare does its business because of environmental concerns. We're actually trying um, to reduce the direct harms that arise from energy consumption in our infrastructure or our mobile supplies, or from the excess use of reusable supplies and the plastics waste that we produce. Um, the intent here actually is to reduce environmental harm and the health harms that come from that, health harms that are not necessarily in front of us. They're not the patient before us. They are often an anonymous person who is not in the same location, because these impacts are global, not local. These pollution impacts are not necessarily local. But these are the intended health benefits of generating more sustainable health systems. But there are also sort of co-benefits, in the sense that there are many changes that we're trying to make in healthcare, fundamentally for non-environmental reasons. When we say we need to reduce low-value care, that is not fundamentally an environmental agenda. There is an environmental agenda that can be attached to that, that can actually help to motivate and mobilize clinicians and administrators to work on that agenda. But the agenda exists because we need to improve the quality of care delivery. That's similarly the case for improving healthcare food. We need to improve the quality of healthcare food because patients are malnourished. They come in malnourished and they leave malnourished. So we need to improve it for that reason, as well as the fact that by improving healthcare food, by plant-forward diets, we can add more locally sourced materials. We can contribute to more sustainable food systems and therefore generate health benefits that way. So there's many things we're trying to do, actually. And in many ways, the majority of things we're trying to do for sustainable healthcare are really trying to yield co-benefits of existing improvements in systems of care that can both improve healthcare systems and improve health thereby, but also reduce environmental harms and improve health thereby. So I think I wanted to answer a question that to me is often lingering in conversations about attempting to make healthcare more sustainable, specifically by depolluting healthcare. And one of the more interesting conversations I've ever had about this was about 10 years ago, when I first talked to an engineer here at U of T, the University of Toronto, about what was then the agenda for deep decarbonization of healthcare. And deep decarbonization is an 80% reduction in greenhouse gas emissions. It was before we started to talk about net zero healthcare, which personally I think is a bit illusory. But in any event, what very significant efforts to reduce the pollution and specifically the greenhouse gas energy emissions of healthcare. And he said, why? He said, why would you do that? And this is a person who works to decarbonize the world. He said, why would you do that? And as he said, and as I kind of pointed out when I was explaining healthcare's responsibility for emissions, healthcare is not the primary producer of pollution. It sits atop the primary sectors of energy, of industry, of transportation, of buildings, of agriculture, of land use. It sits atop them. And as these sectors depollute, healthcare depollutes. It's also the case that I think many of us grapple with this, that healthcare has, one might argue, more important priorities. For many low and middle income countries, we are nowhere near achieving the Sustainable Development Goals commitment to universal health coverage. It's stalled. It may even be going backward in terms of achieving that. And for all countries, low and middle income as well as high income, the priority to achieve equitable and high quality care remains before us. It is not dealt with. And as that engineer said, perhaps when we think about these issues, we should say, there's more important things to work on, and healthcare should be the last to sacrifice. So I want to respond to that challenge because I think it's an extremely important perspective. It's a legitimate perspective and one I respect. I don't agree with it, however. I think that much of what we're talking about, much of what I'm trying to argue for, is that what we need to do to depollute healthcare is actually what we need for high quality and equitable care. There's a lot of potential for alignment, even those efforts that go beyond what we already need to do, like reusables, aim at alignment with our primary goals for quality, equity, and accessible healthcare. The other thing to say is that when we think about healthcare's accountability for pollution broadly, even that which it doesn't directly control, we're advancing an argument from the perspective of demand. We're saying that as users, as big, powerful, important users of these services and supplies, we have an influence. The criticism that my engineering colleague made was a criticism from the supply-driven view of change, that all we really need to do is change the inputs into the world that is. But from a demand-driven view, we're actually saying we have a lot of influence over here from the demand side. The way we design and deliver our healthcare systems has a big influence on the broader world, socially and environmentally. And what we're trying to do is do some things differently, not just supply what we already do in different ways. So I hope that this brief overview has given you an understanding of the range of ways in which healthcare is a highly polluting enterprise, and also some sense that there is a growth of interest and energy around the potential to make health systems more environmentally sustainable. That as we move this agenda forward, it's very important, in my view, to clarify that what we're trying to do is, yes, some specific efforts that are about using less polluting alternatives, but it's also about these broader agendas for transformation and improvement that relate to matching supply and demand and reducing demand, matching supply and demand and reducing demand. So I would say that a wide range of public health disciplines and many beyond have a role to play in all this, and few of them have been adequately engaged. The last slide prior to this one, I think, pointed to the direction of health ethics, bioethics, public health ethics, population health ethics as being also another space where we need some deep engagement. So I think there is real opportunity to improve practice policy and public health education as we grapple with these challenges more deeply. And I'll stop there.
Okay, thank you very much, Fiona, for this brilliant overview of the impact of the healthcare system and how to mitigate this. It really resonated with me. What you said last was preventing disease and this is essentially touching the core of public health. Each case prevented, each hospitalization averted, is decreasing the demand for the system and thus also decreasing the pollution. Thank you very much. This is now, before we continue with the next speaker, I would just like to reiterate the invitation to to all participants to please put your questions into the Q&A box of the Zoom session, and then we can address these questions afterwards in the Q&A session. You can also address the questions specifically to one or two more panelists. Now I would like to continue with the next participant, which is Laura Barangu. She will present a case study, the first one of today. Linda Barango has been empowering healthcare organizations improve environmental stewardship since the 1980s. She has led organizations and projects to reduce healthcare waste, toxic chemicals, energy, and water while enhancing circular economy practices and supporting excellent care. The projects Linda has led for the coalition have been recognized by national and international awards promoting energy efficiency in healthcare and action on climate change. For 9 years, Linda led the coalition as founding executive director and stepped aside in 2019 to focus on the climate emergency as senior advisor, climate change, where she supports the healthcare workforce prepare for and adapt to the impacts of climate change and health. So, with this introduction, I would like to pass on the word to you, Linda, and I will stop sharing my screen now, so invite you to share your screen. The stage is yours.
Can you see my screen?
Yes, it
Okay,
works.
excellent. Thanks so much for the invitation to share our healthcare decarbonization projects that we're doing at the Canadian Coalition for Green Healthcare. I'll be speaking a little bit about those and just wanted to introduce who we are, first of all. We are a charitable organization. We've been around for about 25 years, and we work with healthcare organizations across Canada. Our North Star is to build a health system that heals people without harming the planet. And our vision is a sustainable, low carbon, resilient, and equitable health system for all. During the last several years, our accomplishments include being named Healthcare Without Harm's North American Climate Healthcare Champion. We co-chair the World Health Organization's Low Carbon Sustainable Health Systems Working Group, and we are an advisor on Canada's initiatives on sustainability to Accreditation Canada, and helping integrate some of those into our standards that the hospitals will be abiding by. I wanted to, first of all, indicate to you what one of the challenges are that I find in identifying and actually undertaking decarbonization initiatives. So it's obvious we need to have meaningful greenhouse gas initiatives. We have to continue to provide excellent care. We don't want to overcome staff in undertaking these activities. But it would be great to save the health system money and resources and to educate the healthcare workforce on climate change. But there are a ton of other co-benefits, as Fiona started to allude to. And those are the things that I think we don't do enough of. We don't do enough on investigating what some of these other co-benefits could be. As part of my discussion, I'd like to share with you 4 examples of projects that we are working on the decarbonization in the health system in Canada. We're preparing Canada's health system for decarbonization and aiming for net zero. We are doing a project on decarbonization in action. We're doing a project on circular clinical care, addressing single-use plastics, and our project on the Green Hospital Scorecard. The first project that I'll talk about is preparing Canada's buildings for net zero. So when I'm talking about buildings, I'm talking about hospitals, long-term care, health centers, and clinics primarily. Our area of focus are low carbon inhalers, nitrous oxide reduction from centralized systems, and low carbon systems that are actually enabled by green teams and by helping healthcare facilities identify their energy planning and baseline greenhouse gas measurements. So we don't actually help them implement, we're getting them ready to implement. Our key activities include networking hubs where we exchange ideas. We've produced a number of guidebooks and toolkits. We do fact sheets and webinars, case studies, and more. And this project is funded by Environment and Climate Change Canada. Some examples of our environmental stewardship guidebooks include ones that kind of give you a quick outline on how to think about implementing decarbonization programs for example, the ones we did in hospitals and long-term care. But we also have very many discipline-specific toolkits and guidebooks as well. For example, on cardiology, emergency care, psychiatry, including radiotherapy, greening the wards, and guides for rheumatology greening. So these are things that these are short guidebooks. They're not meant as overly encompassing, but it starts to give people an idea in the sectors that they work in and the disciplines they work in on what they could be doing. Our toolkits include some of these. One of the toolkits we did was in the food system, and we're aiming to help healthcare facilities identify low meat or so plant forward meals. And we worked on that with a number of people from universities and academic associations, as well as doctors that think of food as medicine. Our nitrous oxide toolkit helps identify your steps to undertake to decommission your central supply that is providing nitrous oxide. I'll let our anesthesiologist guest talk further about this, and I won't dwell on that now. One of the things that we are doing is trying to create materials that can be easily assimilated and identified um, and 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 really for people who work in healthcare systems, they're very busy people, something that they could look at quickly to identify something that they could possibly do. We've been told by many healthcare workers that our low-hanging peach tree is one of those infographics. So in this diagram, we're showing peaches of various heights in the tree, which show, for example, where there might be greater greenhouse gas emission reduction opportunities, and the size of the peach itself on how big that might be. And if they're lower to the ground, it's easier to do. And so it's just something that captivates some of the people that we work with, and it's used as a great tool that way. However, I suggest if you're interested in learning more detail about the initiatives and how to implement them, the playbooks that Fiona was talking about, that Cascades has developed, are an excellent resource that are much more detailed than these kinds of things. Our second project is a decarbonization in action project. We are funded by the Peter Gilligan Foundation in Canada, and we are really set to empower hospitals to reduce greenhouse gas emissions across buildings and clinical operations. We have a number of activities that we do here. We help with the implementation support and technical expertise. We actually tell people that we're working with, including on the clinical and facility side, to think of us as an extension of their decarbonization team. We're looking to amplify the implemented decarbonization solutions so we can share all the things that we're learning. The best practices we're sharing through our knowledge and implementation network. And we're looking at systems level change for scaling hospital decarbonization as well. And we have developed, in the process of developing, a solutions atlas, which identifies and clearly outlines one of the things that many hospital staff are telling us is they just don't know where to start. By looking at a solutions atlas, this could be one way that they can start to identify projects of interest. So I'll talk a little bit about some of the projects that we have started to implement already. One is in the dialysis waste area. And in the dialysis process, waste acid is used, and really a jug is used per dialysis system, dialysis cleaning, and it's 30 to 50% of that acid is actually thrown down the drain because it's not, all of it is not used. So this particular hospital in Toronto developed a centralized acid delivery system. They reduced 95,000 liters of acid, as well as a lot of plastic waste in the jugs, 28 tons of greenhouse gas emissions, and along the line, they also saved greenhouse gases. Some of the co-benefits here include not having to lift those heavy acid bottles and reducing strain on the healthcare workforce, as well as storage space being opened up in streamlined delivery. We are doing videos, selected videos here. We're doing one on the dialysis system at the hospital that we're working with, and any other videos that we can find online, such as from the Center of Sustainable Medicine in Singapore, we're helping promote as well. In terms of a systems change, and again, I won't dwell on this because I think our next speaker will talk more about this, but in Canada, we've seen a really great uptake of desflurane-free hospitals. And this started to happen just a couple of years ago when there was only a couple. And now we're seeing whole provinces and territories actually take desflurane out of their formulary. The alternative, of course, sevoflurane, is much cheaper as well, saves the hospital lots of money. And in terms of our low carbon and climate resilient atlas, it is including the low carbon materials, but we're also adding climate resilience as well. One of the things that I think is really important is to consider low carbon and climate resilience to do it together. It makes the climate resilience part a lot more cost effective to do. Our third project is circular clinical care, single-use plastics reduction in healthcare. And thank you, Fiona, for introducing this area as well. We have partners in one of the hospitals, Hamilton Health Sciences, and we work with the McMaster University Medical School, the postgraduate medical education folks. It's a 3-year project funded by Environment and Climate Change Canada. And we're really interested in helping healthcare identify what is it they can do to reduce single-use plastics. Our pilot hospital has identified these 4 areas of interest: perioperative care, textiles, food-related services, and packaging wastes. We're undertaking business cases and case studies. And I'm going to talk about a little bit of a couple of these so you can get an idea of what they are. And if you want more information, you can just click on that note there. So on the direct IV push, we're actually removing IV delivery systems and replacing those with direct IV push, which is through a syringe. So we get rid of a lot of the tubing and the bags that are used in the IV systems. One of the hospitals in Alberta has done this with ketorolac, and I've saved quite a bit of money doing this from the medical supply and reduced greenhouse gases, and significantly are reducing the nursing workload, administrative time, decrease in patient discharge time, and of course, reducing the number of mini bags used. But patients have been reporting that this is a much more positive experience. Reusable surgical masks, these are approved by Health Canada, and these were being piloted in a hospital in Montreal. Again, we found that by reusables, as Fiona mentioned, there is a significant amount of savings on costs, on total greenhouse gas emissions, and other natural resources like water, and reduction in plastic waste, of course, significantly. Endoscopy, which is a practice that is done throughout the healthcare system, has traditionally used sterile water in its process. And we have been switching to tap water in these processes. Many peer-reviewed articles have been written in the last several years on that this is actually a useful practice. Staff feel motivated to do this because they're participating in a greening activity. We found that in the hospital we're piloting this that there's a savings of over $10,000, reducing plastics waste and, of course, greenhouse gas emissions. The fourth project that I just wanted to introduce to you is the Green Hospital Scorecard. The Coalition has been doing this benchmarking program for almost the last 10 years. Hospitals fill out a scorecard, and then they can compare themselves to their own practice over the last several years, and also to others that are similar to them in their cohort. We recently entered into a collaboration with Accreditation Canada and Health Standards Organization to integrate these climate action criteria into the standards and accreditation process. And we're excited to actually see the next steps. They're going to be announced shortly. But in our revised Green Hospital Scorecard, we've identified these 10 practices and areas which we are focusing on in the next stage. We have many other decarbonization projects at the Coalition, and you can check our website to find out a little bit more of those. And thank you for listening, and I look forward to having some discussions later.
Thank you so much, Linda. That was a fantastic presentation, and especially all the tools that you showed us. I think a lot of them, if not many of them, can be adopted around the globe. Certainly, and a thing that we can touch upon in the Q&A session a bit. Um, so advancing and coming next, we will be having a representative out of the system itself. And let me just pull this up here. Yes, perfect. Yeah, so our next speaker will be Dr. Arash Mutamed. He is from the clinical side. He is a clinical associate professor of anesthesiology, vice chair of clinical operations, and medical director of the main operating room anesthesia service at the Keck School of Medicine and the University of Southern California. His clinical and research interests focus on perioperative quality improvement, organ transplantation, and geriatric cognitive health. Dr. Mohammed also chairs the medical center's patient safety and quality committees and serves as the medical director of sustainability for Keck Medicine of USC. Since 2020, he has led the transformative initiatives to reduce the carbon footprint of the operating rooms, including the elimination of disfluorine and nitrous oxide and significant reduction of waste from other volatile anesthetics. I think that's a beautiful continuation of the presentation that we have just heard on reducing nitrous oxide and other components in the clinical field. With this, I would like to pass on the word to you, Arash, and I will now stop sharing my screen and invite you to share yours, and then the stage is yours.
Great, thank you. Are you able to see my screen currently?
Yes, we see your screen.
Okay, perfect. Well, hello everyone. I'm very excited to be here today, reviewing a particular case at our medical center of removing nitrous oxide, both in the form of tank and cylinder. I know time is limited, so I'll jump right into it. In terms of financial disclosure, I do work with GE Healthcare in figuring out ways to remove greenhouse gas emissions from anesthetics, but it's the other types of anesthetics and not nitrous oxide, so it should not impact this talk today. For learning objectives, I'm going to spend just very briefly talking a little bit about nitrous oxide, its history, clinical applications and uses, what the environmental concerns are, but really the focus of the talk is going to be figuring out and walking you through the steps of implementing this change and overcoming barriers. The first thing I wanted to say, because I run into this very frequently, is nitrous oxide is not nitric oxide. Both are medical gases that are used in many health systems. Nitrous oxide much more frequently used, but it created a lot of issues even in just conversation in my own hospital trying to get rid of nitrous oxide because of that confusion. So why are we talking about anesthetics? Both nitrous and the other volatile halogenated agents, as most of you may know, are significant contributors as greenhouse gases, and we've known that since the 70s. And as mentioned earlier, it's a significant chunk of the healthcare greenhouse gas emission, considering how big and wide healthcare delivery is for an anesthetic to play this much of a role is pretty significant. Quick history, discovered in the late 1700s, and soon after that, the laughing gas term was coined because of its euphoric properties. About half a century later, it started to have medical use in dentistry, but really picked up in the 20th century as part of a component of balanced anesthesia with expansion in obstetrics, emergency medicine, and for procedural sedations. So much so that, when you think about all of our anesthesia machines, there is pipes directly being connected to the anesthesia machine. And the only three gases that do that is oxygen, air, and nitrous oxide. So very much a big part of anesthetic delivery in 20th century and continuing. But, in the last, I would say, decade to do a lot more concerns about its greenhouse gas effects and also recreational abuse of nitrous oxide. The two forms of nitrous that we get are either through the portable cylinders that can come in different sizes, but most commonly it's the E-type cylinder and also the central supply. Clinical advantages of it, it's relatively inexpensive as an anesthetic. It's got widespread availability, hemodynamic stability, minimal respiratory depression. But honestly, as far as anesthesiologist use, I think a lot of it just has to do with the fact that it's quick onset and quick offset. And when I'm talking about quick, it's usually a matter of seconds to maybe a minute or two at most. But, in the operating room, we always try to be efficient and quick. So, that has a nice draw for us as anesthesiologists. But there's some disadvantages to it as well. It's not a complete anesthetic. It can expand and close their spaces, meaning we can't use it for all types of surgeries. There's a risk of postoperative nausea and vomiting, which is becoming more of a quality issue in the recent decades. And also inactivates vitamin B12 dependent enzymes, which means long-term exposure to it for healthcare providers or people who misuse it can have hematologic and neurologic impacts. And one of the areas where leads to this talk is its propensity to leak from the central pipelines and, of course, the negative environmental impact. So what is the climate impact of it? It's the third most significant long-lived greenhouse gas after carbon dioxide and methane, with a global warming potential of almost 300 times of carbon dioxide over a 100-year period. And some studies have looked at, if you were to compare 2 liters per minute of nitrous oxide flow and look at its carbon dioxide equivalent, at 1 hour, it's equivalent to a car driving about 100 miles or 160 kilometers, which is pretty significant when you think about the tens to hundreds of millions of surgeries that are being performed globally. The other part of this is it's lasts in the environment for a long time. So atmospheric lifetime is about 114 years, which means most of the anesthetics that were given as form of nitrous in the last century is still somewhere in the atmosphere and also contributing to ozone depletion. And as I mentioned, the leakage is a big deal, and many really good studies have looked at this, and it ranges anywhere from mid 70s to 95%. And why that's really critical is this is something that is not impacting patients in a positive way. So 95% of that is not hitting the patient; it's just directly leaking into the atmosphere, and most of that is through the central pipeline. Our society in the US, American Society of Anesthesiologists, put out a statement in 2024 recommending decommissioning of the pipeline and saying that if there's a need to use it, to use the portable cylinders or on-demand systems. And I know the same is true with some of the other societies in the UK and Europe. So then the question becomes, when we know what it does and when our own societies say, don't use it, why do we still have it? And why do so many institutions still use it? And that really leads to the talk today of figuring out how to overcome the barriers to change. And I'll go through all these steps minus the knowledge gap, only because we've done a fair amount of that in my institution before we even began the process of removing nitrous oxide. One other thing I want to say, and some of you may be very aware of it, is when I'm talking about diverse stakeholder perspectives and established clinical habits, it really means our physicians and nurse anesthetists. There's usually strong opinions, ego, and it's difficult to get them to change. So that's really probably the hardest part of convincing a department, in our case, about 200 people to be able to change practice. But there's also some perceived clinical necessity and coordination complexity with removing and decommissioning. And also, I'll talk about this, the perceived cost of decommissioning. So our journey began in 2023 in 2 different hospitals as part of Keck USC. So with the first hospital, we fully removed nitrous oxide in 23, and then the other one in 24. Just a few words about our center, the 2 hospitals, not really big hospitals, but highly focused on tertiary, quaternary care. We don't have emergency medicine, we don't have pediatrics, and we don't have OB, which means most of our patients are transferred from other hospitals for higher level of care. About 60 physician anesthesiologists, 40 nurse anesthetists, and about 90 trainees in forms of residents and fellows. So my approach to this, and to be honest, I'd already made up my mind that we're going to remove nitrous oxide from our perioperative space, but it was figuring out how do you nudge the group to also come to that consensus and that decision without having to force it. So what I decided to do is to reach out to about 22 of our anesthesiologists and nurse anesthetists that had either formal or informal leadership role. I call them my kick influencers, and that's because they can either help make or break any project that we have. So I wanted to engage them first, and the question I asked them was touching on clinical necessity, because that's usually the way I think physicians kind of get away from doing what we would want them to do is, they would make the arguments that something is clinically needed. So my question was, are there any cases, any surgeries that we do that absolutely requires nitrous oxide? And, I had about a 68% response rate, and 60% of them indicated no. I also have to be honest to say, even before doing this, survey to them. And I knew a few of them who were sort of aligned in that thinking and encouraged them to make sure that, they share their opinion. So we got a 60% no. 13% of them still said no, but said, there may be use in terms of training and education, which I don't really personally agree with, but it's still a valid concern. And so from that, what I took away was, I have the green light to start to engage more and have that conversation more, because the majority of them understand that nitrous is not 100% needed for all cases, so we can look at options. So when I gave them the options, I decided to kind of pick the two extremes and the one in the middle, which I hope people would pick. So the first option, and again, this is asking the same group, is should we keep everything connected to the machine, meaning the tank in the central pipeline? Should we remove the central pipeline but have the tanks available for requests? So this was the moderate option that I was hoping they would pick. And then the final one was removing everything without any replacements. And, not surprisingly, 68% of them said it's okay to have disconnect the central pipeline and have the tanks upon request. So then the next step for that was, how do we create a robust system so that if anyone ever needed a tank, that they would have it on demand? So we created the little guide that you see on the right. And then we began partnering with our anesthesia techs, facilities, and we needed to bring in GE Healthcare. Our anesthesia machines are GE, and because nitrous is connected to it, the moment you remove it, it gives a lot of errors and doesn't function. So we needed them to come in and reset. But through the help of these different teams, we were able to disconnect the pipes and also create an on-demand system for the tanks. And I will say that, since 2023, having done many tens of thousands of surgeries, the tanks were only requested twice, and that was in the first 4 months. And then after that, they were never requested again. Just a few words on decommissioning, and it was interesting for me when I saw on Linda's slide with the guidebook that they use the term deactivating, which I prefer more, because I think decommissioning terrifies hospital administrators, because it also implies, going into the building and tearing out the pipes that are in the building, and you absolutely don't need to do that. So from our point of view, what we did was we physically disconnected the pipes and the manifold system, removed the holes from the walls and ceilings and boom connections, and just capped and placed plate covers. So highly, highly inexpensive, just needed a few individuals and a couple of hours to do that for all of our anesthetizing locations. One thing that I thought was very creative that our facilities management team did was pressurizing the pipes with nitrogen. And this allows the hospital to maintain the infrastructure for potential future use down the line. And obviously, nitrogen does not have the same impact as nitrous oxide, and it's fairly inexpensive. So I thought that was a fairly unique thing that they did that was very helpful. Not that long ago, about maybe 4 months ago, we reached out to our group again, but this time all of our providers, and asked them what they thought post this intervention about removing nitrous oxide. And 92% of them approved, which was also nice to see. And from my point of view, a lot of this had to do with the education that also had happened during this time continuously in our department. There were also positive responses on that survey on awareness of the environmental impact of nitrous and agreement on the importance of sustainability and climate change within healthcare. So what was the actual impact? It's really difficult for us to assess prior to the 2020 era. Most of our sites were on paper records and not electronic records, so it's hard to know how much of nitrous oxide was being used. And then 2020 to 2023, we were impacted by COVID-19, so volumes were not really the most accurate. So it's hard to make that determination, but our best estimate for the 3-year total was 1,775 metric tons of CO2 that was avoided either through use or losses. And then finally, with timeline and conclusion, so 2023, we removed it from Keck Hospital, which is the major hospital that we have. And 2024, we moved it from the Norris Comprehensive Cancer Center, which is a smaller sister hospital. And the only reason for the difference in timeline is, during that time, other priorities kind of got in the way of us doing it. There wasn't really any operational obstacles. And I truly believe that with education and time, the resistance can be transformed into support, and we were definitely beneficiaries of that. And then just general challenges of nitrous oxide, even though in big health centers, we're seeing the push to remove nitrous oxide, its use is going up for procedural sedations, at least, here in the US and, outpatient clinics. And also the recreational use of nitrous oxide is also unfortunately increasing. So, two other areas that will, impact in terms of, the greenhouse gas effect of it. And then finally, we were able to publish the work that we did fairly recently in the Journal of Clinical Anesthesia. So if anyone's interested to read about it in more detail, feel free to look that up. And thank you for giving me the time and opportunity to talk with you today. And that concludes my presentation.
Fantastic. Thank you so much, Arash, for showcasing this initiative. I think it's a great example of how this can really be implemented on a local level and putting it into practice. With this, I would like to now open the Q&A session. We have roughly 15 minutes left, and we have obtained quite a list of questions coming in from the audience, from the participants, and I'm going to rotate through the panelists now in the regular order and direct one question to each one. But if you feel that one question might touch your area of expertise, please feel free to jump in. So we might start with Fiona Miller. There was one question reaching us. And this person is asking, how do you think green healthcare initiative from Healthcare Without Harm fares compared to the factors you mentioned, if you are familiar with this green healthcare initiative?
I thought that was better positioned to Linda, actually.
Yeah.
Linda, do you want to try that one?
Could you just repeat that, please?
Yes, of course. So the question is, how do you think green healthcare initiative from Healthcare Without Harm fares compared to the factors that you mentioned?
Okay, so factors that Fiona mentioned.
Yeah, I assume so, yes.
Yeah, so there's a combination here, Fiona. So from my understanding, Healthcare Without Harm is addressing some of the things that Fiona has brought forward, like the reusables, like the plastics. There are many initiatives that Healthcare Without Harm actually undertakes. Fiona.
Yeah, I don't feel like I'm well placed to judge Healthcare Without Harm. They've been in the business for a long time. They do a lot of things. I was trying to place, just provide a framework, which, as I say, comes from Andrea McNeil and Jody Sherman and Forbes McGain in terms of how we conceptualize that. There's a prior really useful framework from the Center for Sustainable Healthcare that Francis Mortimer and colleagues published in, I think, 2018. That's similar in terms of conceptualizing what we're trying to do around these issues that are both specific to the depollution as well as the broader impacts. I just think that the image that Andrea McNeil and colleagues have put together in the 3 buckets are really easy to remember, and they map clearly, particularly for a public health audience and a broader clinical audience, and thinking about the work we're doing here, that some of this is quite specific. It requires the kind of expertise that Linda has in spades in terms of all of the very specific things that need to be done, but some of it is much more general in its relevance to health professionals and public health professionals. I'm afraid I don't think I can answer the specific question as to how it lines up with Healthcare Without Harm's work.
Okay, thank you very much. Then I will try to summarize a couple of questions that go into the same direction for you, Linda Barangu. It is essentially people congratulate you on the different projects that you have going on, and they ask how these activities and the tools that you provide, how they could be scaled up internationally, especially also looking at lower and middle income countries.
These are all publicly funded tools. Happy people going to our website and looking at them and using them. If there's some collaborations possible, I'm sure that's a wonderful idea as well. But yeah, these are publicly funded and be great to have other uses.
Okay, Fiona wants to jump in there.
I just wanted to jump in. I'm sure Linda would say the same, that the Aga Khan Health Service, I can't seem to post to the broader community, but I did post it in response to the chat that the Aga Khan Health Service is probably one of the first health services in the world to actually commit to decarbonization. I think it was 2019. So there's quite a lot of work that's happened there, and incredibly accessible tools that are very similar. So not to disagree with at all, I think the tools that the coalition has are tremendously valuable and can be used all over the world. I think that that's true of Cascade's tools, although, as Linda said, that the coalition tends to conceptualize more focused ways, and we've got some broader, deeper decks. But I just want to point specifically to the Aga Khan Health Service as providing just some, and I'll post it here to the hosts and panelists, so maybe it can be posted to everybody else, that link, because they've got some resources and experience, and a lot of this is in lower middle income settings when they've done this work. So this is not exclusive to high income countries by any stretch of the imagination.
Okay, fantastic. Thank you very much, Fiona. To what I understand, all links and resources will be shared eventually on the on the website that every participant has permission to go onto. So these should be reaching all the participants of this session today. So, and then going next to you, Arash, there was one question directed to you. How do you foresee increased education mitigating the future challenges from nitrous oxide? Or maybe I could expand this question a bit. How do you see the role of educating and your colleagues and residents and other colleagues from the hospital and following your example?
Yeah, thank you for that question. It plays a very vital role in that I got involved in the space because I went to a really great lecture by a student. So this was a student who was interested in anesthesia and gave a talk, and I still remember it clearly. I then recruited him to become a resident, and then now he's a faculty in my department, so it worked out really well. But I sat in a lecture with the student talking about the impact of greenhouse gases and aesthetics and desflurane and nitrous oxide. And for me, that was my sort of light bulb moment and how I got involved. So I think education is incredibly important. And we live in a world where there is, especially where I live, a lot of disinformation when it comes to the impact of our existence on our environment. And I think the best way to combat that is expose the truth. And the way you do that is through education. So, more locally, it helps us stay focused. As the talks earlier were mentioning, I thought it was really interesting, the question of should we really focus on decarbonization in healthcare when the focus is, patient care. And that is always the primary focus. And sometimes that is such the focus that you keep forgetting that there's other avenue, this other side of, being responsible stewards to our environment. So we do continuous education in forms of whether it's lectures, emails, faculty meetings on a monthly basis, pick different topics and talk about it to just make sure it's always in the back of the mind, because it's really easy to put a lot of effort, put a lot of focus, do it, and then with time, it just goes away.
Okay, beautifully put. Thank you very much. Then I have a next question directed, in theory, to you, Linda, but I think probably everyone can touch on this question because it's a phenomena that we can see in every field and every level. So the question is, has there been any opposition to your tools or programs, and how did you overcome that kind of opposition?
Great question. We have challenges all the time when we approach ideas going into facilities. But I think one of the ways that we approach this is by aligning ourselves with champions in the facility that we are engaging with. And that champion then has the network internally to help others that may not understand the value of going forward with what we're talking about to bring those people on board. The other challenge, I would say, on the senior management side, often senior management is not necessarily aligned with climate action, decarbonization. And I think the great opportunity we have here is in Canada is working with Accreditation Canada, because once these become embedded in the accreditation process, it is on every senior manager's radar. And it's no longer a question of, should I do this? But I must. And so I think our trajectory in going and working with small groups of organizations and facilities has moved forward so that we can spread and scale this at a level that we didn't envision a number of years ago by having this partnership.
Okay, fantastic. So I understand accreditation is a crucial step to help this and to overcome opposition and put it on the agenda of senior managers. Fantastic. So then we probably have time for one or two more questions. One is directed to you, Fiona, and it's about pharmaceuticals. And I will combine two questions here. First, is there a safe and sustainable way of reusing pharmaceuticals once they have been expended to the customer or to the patient? And linked to that, are there alternatives available to substitute plastics in pharmaceuticals or in healthcare in general?
So the easy questions. So I mean, I think the question of reuse or is quite jurisdiction specific, because there's going to be regulatory issues that are going to, say, in the Canadian context, restrain that. That's not permissible. It's permissible in some jurisdictions. I think that we have to recognize that some of the yield from those efforts could be significant, but not always. And I think this is where we get to the question of overuse and inappropriate use. There's a lot of excess and inappropriate use. And when I talk about the problem of low value care, that's tests, that's procedures, that's medications. If you think about the aging population, the problem of polypharmacy is very, very real. We don't do enough to address that challenge from a clinical perspective in terms of what's really happening with this patient, and the challenge of the pharmaceutical cascade, where we give somebody one medication, then there's adverse effects. We give them another medication, adverse effect, another medication. So that more holistic take on this. My own view is that the growing scopes of practice of pharmaceuticals of pharmacists as they take on a broader scope of practice, as is happening in Canada and around the world, means that some of that expertise that they bring to these decisions will support improved medication management and reduce some of the inappropriate use that's quite possibly harming patients as well as the environment. So the question of switching out green pharmaceuticals, is a challenging one, or reusing ones that exist. There may be opportunities, jurisdiction specific, but we must not lose sight of this larger question of quality care, where there is misuse, inappropriate use, and the potential to really significantly take a dent out of the environmental impact from that perspective. In terms of plastics, I mean, I guess I want to answer that question by speaking about what I consider to be potentially a non-solution, which is bioplastics, which is both an ambiguous concept. What do we mean by that? Are we talking about biological inputs? Are we talking about potential for decomposition in terms of composting? So it's a very poorly kind of regulated in terms of standard terms. And the yield is often not going to be what we hope it to be, both because if it's a biological source to these materials, then there are environmental and social issues in terms of biological sources to plastics. And in terms of the other side, which is the decomposition, we really don't have composting capacity other than at industrial scale. And a lot of composting industrial scale facilities still can't do this well. So you can contaminate your waste stream, you can make the composting systems that we have not function. So I think again, a lot of the simple solutions are going, in sort of like, let's find a technological alternative. We got to be a little bit cautious about whether the evidence is really there to support that. So again, the issues of reuse that both Linda and I were pointing to, and reducing use, again, overuse is where I can't stress enough how much I think that it's from the healthcare delivery perspective, it's in that matching supply and demand space where there is an enormous potential for yield that isn't going to run into some of the non-solutions that, say, bioplastics are.
Okay, beautifully put. Thank you very much, Fiona. And I think the last question, I will allow myself to put the last question and address them to you, Arash. As a fellow medical doctor, I know that almost in every country worldwide there is national medical guidelines in almost each specialty. How do you estimate the possibility or the potential of introducing the deactivation of nitrous oxide in the national guideline, the US American one for the anesthesia?
Yeah, it's a great question. I think for me, I'm also involved with our society, so I think it's also important for for all of us to, as physicians, be very engaged with these societies because they help set the tone. So more locally, and part of our California Society of Anesthesiologists and part of the sustainability group there. And these smaller state societies help feed into the American Society of Anesthesiologists for us. So it's sharing, again, it's the education, sharing the information, helping set that up. And the thing that I realized in a lot of those conversations was there is this panic around the word decommissioning, and everyone just suddenly wants to put a stop to it because, I don't want you to come decommission and take out pipes and bring in regulatory bodies to come and take a look. And really all it's meant by it is just cap and plate the connection. So again, it's a combination of education and then involvement of, the physicians in who are interested in these initiatives to get involved with the societies and help push that agenda forward.
Okay, thank you very much. So there is indeed potential and the possibility, I understand. We have now reached the end of this session of the webinar series. I would like to thank all of you very much, all the participants from all parts of the world, but of course, especially our three panelists today, Fiona, Linda, and Arash, for joining us and sharing their expertise, knowledge, and experience with us. And with this, I thank you a lot, and would like to close this session and see you next week, same time, same place. Thank you very much, and goodbye. Have a great day.